So you arrive on labour ward, and if there's a birth plan, that's great. It will tell you what mum's viral load is, it will tell you what the risk to the baby is, and it will tell you what your role is, which usually is just to write up oral zidovudine. You'll write up the oral zidovudine, you need to make sure that the midwives give it, and then the baby will need to be booked in to follow up. And that's usually fairly straightforward. However, if the mum is unbooked, and this does happen, and turns up, what do you do? Well, the first question is, do we know what mum's viral load is? If you don't know what mum's viral load is, then what you need to do is start triple therapy on that baby. So you need to start oral zidovudine, oral lamivudine, and you need to start, and the third drug has gone, zidovudine, anabacavir, sorry, the third drug had gone out of my brain. So you need to start 3 drugs. You hopefully will have a local protocol for this. Preventing breastfeeding. Now, this is slightly controversial. There is now a number of pieces of work, especially coming from developing parts of the world, that suggest it's probably reasonably safe to breastfeed. However, that's in a mother who's on antiretrovirals, whose viral load is down. In a mum who has delivered a baby that is unbooked with no treatment prior to delivery, who is HIV positive, then breastfeeding absolutely is not a safe thing to do. And we would strongly recommend preventing breastfeeding, stopping breastfeeding. What that means in reality is getting mum's agreement, offering a drug like cabegoline to mum in order to suppress her breast milk production, and also supporting her with explaining to the rest of her family why she's not breastfeeding, and that can often be really stressful for mums. The other thing is, if the mum is unbooked, don't forget about hepatitis B. We're not going to have a hepatitis B result straight away, and therefore this is a baby that should be immunised at birth. If the baby is preterm and it's an unbooked pregnancy, or the baby is nil by mouth for some other reason because it's unwell, then we can give zidovudine intravenously, but it's actually the only one of the antiretrovirals that is available intravenously. Where you've got a really, really high risk mum, so for example, a mum who's unbooked with a very high viral load who comes in and precipitously delivers her baby, then we also sometimes use a drug called T20. It's a fusion inhibitor. It's not been popular in uptake because it's given subcutaneously, but we have used it intravenously, and there are a couple of papers on that, one from St George's a few years ago now, and we have used that when we've been really scared about the risk of transmission. If the mother has booked during the pregnancy, then we now stratify the risk to the baby, and we stratify that risk as low, intermediate or high, and that determines how long the zidovudine will be given for and whether it's just zidovudine we give. What do you do if the test is refused? What do you do if a mum turns up unbooked in pregnancy or turns up having refused to previously be tested for HIV? What do you do in that scenario? Do people want to put stuff on the chat? Can everybody see the chat, or do I just see the chat? I'm not sure. If everybody can see it, do people want to put ideas on the chat as to what you would do? For example, would anybody say to, everyone can see the chat, Katie says, great. So are there people who feel that if mum refuses to have an HIV test, you should do nothing at delivery? I'm not sure asking questions is going to work, but let's see if anybody responds to that. So Layla said, give the meds in any case until the PCR is back on the baby. Sounds reasonably sensible. Caroline says, test the cord blood. Any other thoughts? Nola says, we'll ask why she doesn't want to be tested. Absolutely. We need to test the baby and possibly start triple therapy. Completely agree. So the first thing is, why doesn't the mum want to be tested? The reason often why people don't want to be tested is because they're scared. HIV is a scary disease. Beatrice said, test the baby, start treatment whilst results are available. So if you test the baby, and I absolutely agree with doing that, because I think the baby has a right to be treated and the baby has a right to HIV prevention. The one thing you've got to be completely aware of is, in testing the baby, you are in fact testing the mother. And I think that you probably have to explain that to mum. You have to say that it's your child's right to, Eleanor's added, sorry, offer counsel and point of care testing to mum. Again, absolutely. I think you have to say to the mum that it's the baby's right to be tested. We're doing it in the best interest of the baby, but in so doing, we will know that your status. I think this is always a complex area. It's always a difficult area. Somebody rightly said we have point of care testing for HIV. We get a result in 2 or 3 minutes. The point of care tests are really easy to use, and that's exactly what we would do. Oh, something has changed on the screen, and can you all still see the talk? Sorry, I don't quite know what's happened. Maybe I was hovering too close to it. So absolutely, we would do point of care testing on the baby, which of course would look at the mum's antibodies, and we would offer the mum point of care testing. Adib has just added, if the mother still refuses, can we test in best interest of child? Do we need to go down a legal path? I think that's a really difficult question to answer because, of course, time is of the essence, and you actually need to get on and test relatively quickly. I would probably argue that we should try and persuade the mum that we're going to test her, or well, we're going to test the baby, but we prefer to test her. If she absolutely point blank refused and we thought that she was at risk, and obviously all unbooked women are at risk, then we would have to try and go down a legal route, but doing that rapidly is often difficult. And I guess I would involve social services at that point, and I would ask for appropriate help. But in reality, this has never happened. When we've spoken to mums in this scenario, I don't remember a scenario where a mum has actually refused to allow us to test her or her baby. So I'm going to move on to a little bit about HIV positive children. HIV is considered a relative immunodeficiency. I'm going to talk a little bit about COVID in a second. So different children will have different degrees of immunodeficiency, and you need to be aware of that when you're admitting a child with HIV, and you need to be thinking about their susceptibility to infection. The two things that will really help you are getting hold of their most recent CD4 count. Is it in the normal range or not? If it is in the normal range, you need to be aware that CD4s are both important quantitatively, but we know that qualitatively the immune system often doesn't work perfectly. So for example, you can have a child with a normal CD4 count who actually can be significantly more susceptible to infection than another child. What you then need to know is their most recent viral load. And what you're looking for is, so Sam has asked, Sam Kure, I presume it's Sam, has asked a question, do you use the same ranges for CD4 in under 1 year? And the answer is no. CD4 changes over time, and you need to use age-appropriate ranges. And there is a gradual fall in CD4 count in normal children through childhood, and you need to be looking and comparing with that. And you've said, thank you, that feels very strange. So you've looked at the CD4 count and you've looked to see whether it's more or less normal, and that gives you some idea about the immune status of the child. But you also need to look at the viral load. If this is a child on treatment, are they fully suppressed? Different hospitals use different levels for fully suppression. In my unit, it's less than 50 viral particles per ml of blood. If they're fully suppressed, that gives you a good idea that they are taking their medication and their medication is effective. So just to give you some examples, I've looked after a little boy from Cameroon who arrived 3 or 4 years ago, and he turned up with a CD4 count of 0%, 4 absolute cells, and a viral load of several million. So he was profoundly immunosuppressed. He also had a number of other infections, which wasn't surprising. He had TB, he had some gut infections, he had some CMV, he had a little bit of toxo as well. And these kids are really difficult to treat because you tread a tightrope. You need to start to treat the other associated infections before you start to treat the HIV. If you just start to treat the HIV, then as the immune system wakes up, you will get into terrible problems with something called IRIS, which is immune reconstitution syndrome. And my simplistic way of thinking about it is that the immune system is waking up, it realizes, oh shit, my goodness, the body's full of other infections, I'm going to mount a profound response to these, and actually the degree of that response can threaten the child's life. So with the little boy who arrived from Cameroon, what was really important was to treat his TB first, and we kind of played a waiting game to see how long we dared to wait before starting antiretrovirals. And what we did with him was, I think we treated his TB for about 4 weeks. We thought we probably got somewhere with his TB, and then we started antiretrovirals. And actually, thankfully, he didn't get IRIS, and he's done really well. And I see him in clinic every 3 months at present. So the next point in HIV positive children is the importance of compliance. I'm sure, like many people who are listening, occasionally I've been prescribed medication in my life. If it's antibiotics, I tend to take it until I feel better, and then I'm pretty rubbish and I stop. And I'm sure lots of us are guilty of that. It might even be the right thing to do. But with these kids, they need to take their medication, and they need to take it every single day. And some of them are on it twice a day. Often the medication is unpleasant to take. It can have nasty side effects. It also can taste unpleasant. If we're using the liquid forms, they all taste revolting. And therefore compliance is a real issue, because what you don't want is a falling viral load that starts to rise and a low level of drug in the system, because that's the perfect system for resistance. And resistance is one of the biggest risks in HIV. So we work very, very hard to support families to ensure that their kids take their medication, that they are fully compliant with it. That then brings in the issue of social background. A number of the kids in my clinic have lost one parent. Some have lost both parents. And that's not uncommon in HIV clinic, especially where a significant proportion of kids have come from abroad. These kids have a difficult time socially. There is an awful lot going on for them. You need to understand what the social perspective is in order to have some chance of getting where you need to with compliance. So a little girl I did a phone consultation with last week. Both parents are HIV positive. So that's my bleep going off. Let me turn that off. Both parents are HIV positive. They're asylum seekers who don't have the right to remain in the UK. That means only mum can work. She works all the hours that there are. That means that she's not around to supervise her daughter's medication. That sometimes has caused some problems with poor compliance. So unless you know that story, unless you understand that story, then you're really going to struggle with ensuring that the child does what you want them to do. Naming. Naming is about telling children they've got HIV. It's also about finding out who else knows in the family. And you would be amazed. I looked after a child who's moved on to adult care now, who at the age of 17, her 20-year-old sister still did not know that she and one of her parents, her mum, had HIV. And this causes terrible, terrible taboo problems within the family. So it's really important to know who knows, but it's also really important to work out when to tell the child they've got HIV. Can we do a bit of a straw poll? What age do people think would be a good age to tell a child they've got HIV? Let's see what people think. I'm going to hang on for a second and see what messages come through. See if anybody's still awake. What age would you tell a kid they've got HIV? So Beatrice says, oh my goodness, it's gone mad. Hang on. Oh, so let me just see if I can. So I'm getting loads of answers. I'm getting, depends on the child, absolutely. 5 to 6, so 7 to 8. Some people have said a bit older, some people have said a bit younger. Hang on, I'm going to go all the way up. 6 to 10, 8 to 9, 7, 10, 6, 10, younger, 7, 7. Depends on the child. Introduced from the start. Depends on Gillick competence. Depends on the child as much as possible, 8 to 10. Depends on the age and development of the child. Earliest could be 3 to 4 years. Wow. The sooner the better. Okay, so there are a number of bits that make this complicated. The first thing is obviously the child has got to understand what you're talking about. And the second bit is you need to remember that HIV still carries a very strong stigma. So we talk about telling children their full diagnosis at 9 or 10 in the clinic where I work, but starting earlier than that to start to talk about that, but doing that jointly with the family. And the downside of this is if you get it wrong and you tell the child before they realize that this is not something they can talk about with their friends, then it can cause terrible problems. So an example would be a child whose dad was really very difficult to work with, very unreliable. And we said, we'll do this about 9 or 10. And at the age of 7, he was watching a film with his daughter and he said, you know those baddies, you've got baddies like that in your blood. It's called HIV and that's what you've got. And she went to school and they did circle time and the teacher said, tell us something that nobody else knows about you. And she sat in circle time and said, Sam, I'm going to come to you in a second, answer your question. And she said, I've got HIV. The children in the group, not surprisingly, didn't respond because they didn't know what HIV was, but some of them told their parents. And she ended up having to leave the school and move to a different school because the reaction of the parents was so poor to her. She didn't get invited to anybody's house anymore. They told their children not to play with her. So the downside of telling a child who doesn't understand that they can't talk openly about this, unfortunately, is really sad. And for that reason, I would argue that naming, it's a gradual process, it's not done at a specific time, but it needs to be done at the point that the child can understand it, but also the point that a child can understand that they can't talk freely about this, which is really sad because if they had diabetes or asthma, they could tell the whole world, but actually if they've got HIV, they really can't until that stigma changes. So Sam said, how do you support parents to explain to a child why they're taking tablets? I presume some children will ask, and you're absolutely right. And the honest answer is you tell some of the truth. You're taking tablets because you've got a problem with your white cells in your blood, and this is to help your white cells stay strong so that you can fight infection. Sometimes that works, sometimes it doesn't. I remember a little boy who probably the age of 10, we were a little bit later doing it with him, came into clinic with the Ladybird book of bugs, open on the page which said viruses and said, Dr. Daniels, what's a virus? And I sussed by that stage that he'd been doing his reading and I'd probably missed the boat in telling him about his HIV because he'd thought about it already for himself. So every family is different, every child is different. Sometimes we do the naming in the clinic. Sometimes Yolette, who's the clinical nurse specialist I work with, does it at home. Sometimes the parent wants to do it, but you have to start that discussion early on to talk about when are you going to do it and how are you going to do it. In terms of medication, most children well, all children now should be on medication. There's very clear WHO guidance that there's no longer any room for waiting and seeing what happens. And most children will be on 3 drugs. Occasionally they will be on 4 because they're having problems with resistance, but most kids will be on 3 drugs. And the 3 drugs must be of at least 2 different types. So what we learned from the very early days with HIV was that you could start a single drug, the viral load would go down, the CD4 count would go up, the patient would get better, and then a few months later they'd start to get sick again. And what we learned quite quickly was that that was due to resistance. So the only way that you prevent resistance is by hitting the virus from multiple different angles, multiple different points in its life cycle. So we use nucleotide reverse transcriptase inhibitors, we use fusion inhibitors, we use all sorts of drugs that work in different ways. We use protease inhibitors. And if you're using at least 2 classes of drug, usually 2 of one class and 1 of another, then you should be able to keep the virus fully suppressed, providing the compliance is good. I'm going to move on next to very briefly talking about COVID. Does anybody want to ask any questions about HIV positive children? And I'll hang on again for a second and let you do some typing. I'm just seeing. Okay, so Sam's asked, how often do you monitor for resistance? So when you start treatment, you would probably monitor every 4 weeks to start with, and then once you know that the viral load is going, sorry, you've asked how often do you monitor for resistance? The answer is you only monitor for resistance when the viral load is not doing what you expect it to do. So all kids should get a resistance test before going on to treatment. And then I would only do a resistance test at a point where I thought the treatment wasn't working or the viral load was rising because of non-compliance. And that's happened for all sorts of reasons over the years. One parent's gone away on holiday, kids taking their medication less well, something else has changed in the family, they've taken it less well. There are all sorts of reasons why viral load goes up, and that's when you need to do a resistance check. You don't usually get a reliable result unless the viral load is above 1,000. And what we do in this country is a genotypic resistance. So we actually sequence the virus, we look at the different points on the virus, and we look to see if there are mutations that would cause resistance. Just to be clear, in the States, they do it the other way around. They look to see whether the virus is still killed by the different medications. So they look at it in a more quantitative way. Saskia said, is it quite rare to see complications these days? It's rare to see kids getting AIDS, so it's rare to see kids with significant infections, unless they're new presentations, and those kids often will come from abroad. But we do see kids who come into the country who are clearly incredibly unwell, like the little boy who came from Cameroon that I spoke about before. Noella Pereira has asked, which 3 drugs do you start for an infant if tested positive? So that's a really, really complicated question to answer. And it very much depends on what the maternal resistance profile is. And actually you have to, so there is guidance, there's Chiva guidance on what you should start, but actually you have to look at maternal resistance, you have to look at the social background, you have to think about a number of things. So it's really hard to give guidance on that. You also need to know, was this a baby that got preventative treatment at birth? Because you may also have induced some resistance from that. So I'm not going to answer your question, Noella. I'm going to say it's something that you need to get advice about, because there are so many different variables. So unfortunately, we've had twins at my hospital who were born with HIV. It's our first transmission in 19 years. We've had 600 consecutive negative children coming up to them. And actually they have proved really difficult to treat because their mum had quite extensive resistance, which also unusually she'd transferred to the children. And that's been really difficult. And Mel's asked what kind of follow-up they need. So I will, once these kids are stable on their medication, I will normally see these kids in clinic every 3 months. Because I run a relatively small HIV clinic, I work with a team at Great Ormond Street. So Delane Shingadia, who's one of the consultants there, comes and does an MDT with me twice a year to make sure I'm keeping up. But I also work with a clinical nurse specialist. In our MDT, we have a psychologist, and that's really important. We also have a consultant pharmacist, and we very much work together as a team. At the moment, we're doing things very differently because obviously we want to bring these kids into hospital as little as possible. And actually we're doing their bloods in the community and we're doing phone consultations with them. Let me move on to the last slide. Let's see if it'll. So I just wanted to talk very briefly about COVID and HIV. And the answer is we don't really know very much about this. There's very, very little data around. One could presume that this cohort would be more susceptible to COVID, and you might presume that the kids with lower CD4 counts might be more susceptible than the kids with higher CD4 count, but actually there's no data to back that up. The kids with decent CD4 counts are not in the shielded group. They are not told to lock themselves away, which is interesting, whereas some of the children you're looking after, particularly the children on biologics, and the children with oncological diagnosis will be in the shielded group. This group of kids are not at present. So what's the advice during COVID? Well, we've decided not to make changes to medication that would necessitate more frequent blood tests, because we don't want these kids coming into hospital. We don't want to go and see them more often. So the twins that I spoke about before, who are reasonably complicated to treat, we were planning to change their medication as they got bigger. And actually, I don't want to make that change until we can monitor them more carefully. There is advice that we should minimize contact. Clearly, coming to the hospital carries a significant risk at the moment. At one stage 3 weeks ago, 90% of the patients, not the children, but the adult patients in my hospital were COVID positive. We do not want to bring people who are immunosuppressed at whatever level into contact with a hospital in that scenario. One of the things that's really, really important, and this has been bashed home to me over a number of years, is the importance of telling people that when they seek help, they or their parents must say that they've got HIV and must mention the medications they're on. I think lots of our population believe that we have really good computer systems in the hospital that will ping when somebody walks through the door, will say that patient's got HIV and they will be taken seriously. And I always remember a kid who I'd looked after for many years who went on to adult care, was doing really well, came in with severe headache, didn't mention her HIV. I think, presumed that A&E knew she had HIV. They said it's a headache, take paracetamol. She went home and she came back 2 days later and subsequently died of TB meningitis. So my learning from that, and it was a desperately sad scenario, is that we have to ensure that the kids, as they're growing up, once they know their diagnosis, know that many health professionals won't know their diagnosis, and they absolutely have to be upfront about telling them. Sam has asked, any data from HIV and COVID in adults? I keep looking for this and I haven't seen any yet. There's been advice from various HIV bodies. So CHIVA, Children's HIV Association, are putting together some advice. BEVA, British HIV Association, have put together some advice. I haven't seen any data in any of it. I think there was one study, I can't remember where from, but there was nothing very useful that I've seen so far. But going back to my point, Adib said, do any of the antivirals used in HIV? Oh my goodness, what a question. Do any of them have any activity against COVID? If only we knew. So we started off using Kaletra. There've now been a couple of papers, Kaletra's lopinavir, ritonavir, that says that probably isn't effective, but I think it's still part of one of the trials. Remdesivir is not an antiretroviral. It was produced originally for Ebola. I don't think it had much effectiveness against Ebola, but that's also being looked at. So there's a big trial going on. I want to say it's called Recovery, but I can't remember if it is. That's looking at different possibilities for treating for treating COVID. But as things stand today, there is no evidence for any of the antiretrovirals. Yes, it is Recovery. Thanks, Gabriella. I'm glad I'm getting something right. So going back to the point in the talk, really, really important to tell families that they must mention they've got HIV when they're care seeking. The other advice we've given them is to seek help early. And the last point in the talk is this Kawasaki variant that is starting to get everybody worried. I think we might be worrying too much. The number of cases have been really small. We've had 2 potential cases at this hospital. These are kids who tend to present with what looks like moderately severe sepsis. They have quite a high lactate. They look unwell. It's not clear what's driving it. We've swabbed them for COVID, and the COVID, I think, was positive in one of our kids and negative in the other. Both kids have gone to PICU, and they've been diagnosed with this new sort of Kawasaki variant that we really know very little about at the moment. You'll see that it was mentioned on the BBC website yesterday. You'll see that various letters have gone out to NHS trusts around the country. I'm really worried that we might be worrying families about something that is possibly not that significant, but at the moment it's really hard to tell. And I think when you're seeing kids in A&E who are sort of non-specifically unwell, you just need to keep it at the back of your mind. I know that's not very helpful guidance, but that's probably all that we know about it at the moment. I think my last slide is next. So I've made 3 points in this talk. Mother-to-child transmission, early intervention is really important, and it decreases the risk of the baby getting the virus. And especially think about testing babies born to mums who haven't been tested. I've talked about HIV being a complex lifelong disorder. Oh, I can't see that. And I've talked about COVID. I can't see what it says, but I think it says something about it being a new risk with unclear data. That is what it says. So I'm going to stop and see if there are any additional questions that people would like to ask, and I'll do my best to answer those. By the way, I would really appreciate feedback at the end of this. It's been very strange giving a talk without being able to see anybody and without being able to talk to people. It's not something I've done before. I hope it's been useful. It's certainly been a learning experience for me. Oh, Gabriella, thank you, Gabriella. Are there any questions though? Everyone's saying it's useful. Oh, there's a survey monkey come round, so it'd be really helpful if people can fill that in. But any questions about what I've said? So Elena's asked, what proportion of young people tend to develop resistance before adulthood? Off the top of my head, 50% maybe have some degree of resistance going into adulthood. This used to be much worse because the kids who were around at the time when there was only one drug all got resistance. And all of them are now in their mid-20s and are in adult care. But when I handed them over to the adult team, I had to say, this child is really healthy, they're doing really well, but by the way, I've blown this treatment, this treatment, this treatment, and this treatment. So actually your options for treating this child in the future are going to be really difficult. And I felt terribly uncomfortable doing that. Things have got much better since then. We've been using triple antiretrovirals since the early 2000s. So we shouldn't see that much resistance, but probably 1 in 2 kids I hand over have some degree of resistance. Any other questions? Otherwise, I will sign off. Oh, hang on. Caroline, going back to mother-to-child transmission. If the mum refuses an HIV testing and the initial PCR from the baby is negative, do you need to recheck again? So I would actually do an antibody on the baby to start with. I know this sounds wrong because you're actually diagnosing the mother. It's not the baby's antibodies, it's the mother's antibodies, because you can get the result much more rapidly. PCR will take several days to come back. You can do an antibody test there and then. So if the baby's got antibodies, the mum is positive, and I would then follow the usual PCR testing, which is 0, 6 weeks, 3 months, and antibodies at 18 months. I would add triple antiretrovirals. I would try and stop mum from breastfeeding. Hopefully that makes sense. Amel says, any special precautions to attend a delivery? I think everybody's hung up on PPE at the moment. No special precautions. No special precautions, and wear gloves. That's about as much as you need to do. Your risk of catching HIV from an HIV positive patient is pretty close to 0. I've had a couple of needle sticks over the years because I'm sometimes a bit careless. You really need to take HIV infected blood that has freshly come out of the baby and inject it into a vessel in order to catch it. And even then it's really difficult. So no, wear gloves for the resuscitation. That's about it. Any other questions? I'm sorry if I've been slightly dismissive in my answers. Brilliant. I'm going to sign off then. I really hope that was useful. And I wish you all good luck with your training and hope the rest of these are useful too. And take care and be safe. Bye.